Yeah, I changed the title a bit. It was going to be the cost, but I wanted to say something about the value as well. And I'm going to struggle with this. So if I press top green. Okay, great. Mine's not timed. Okay, I'm going to begin with the easy part in this presentation. I'm going to talk to you about benefit-cost ratios for TB, poverty impact, cost effectiveness, the standard arguments that have been made for the last 20 years of why we should be investing in TB. But hopefully, if I speak quickly enough, I will also talk about the challenge and the gaps of actually making these arguments at the country level and what we've learned from that. Just intuitively, without going into all the complex models that were mentioned for polio, which still exist for TB, and we have all those kind of complexities too, the simple economic case for TB is it has a very high mortality rate if left untreated. It is the leading cause of death globally from infectious diseases. On average, it affects people in their working age, so one death averted leads to a lot of health gain. And the regimen cost itself, and I'll come back to what the true cost is, but at least the regimen cost for drug-susceptible TB cases is as low as $20 in lower middle-income countries. And not only that, clearly, because it's an infectious disease, the way to prevent onward transmission is by early treatment of the disease. So like HIV, treatment is prevention. Using those simple numbers, playing around with them in different countries, we see time and time again a very strong investment case made. Here's an example for work we did for The Economist, which goes through all the development interventions, and TB was in the top 10. We've done similar exercise at various country levels. You can't read it, very small print, but I like the newspaper. That was in Bangladesh. They looked at 221 development interventions. TB was the top investment in terms of development intervention, so not just in terms of health. Of course, that doesn't apply to all countries, but that's just to give you an example. It's never been a difficult case to make. Having said that, we talked about the $20 cost. This is from the WHO TB report. This looks at the costs on average now of treating TB patients across different countries. And you see when you start to take into account health system costs and the various things that Thomas mentioned about what it actually takes to treat those costs are substantially higher. But still, in some low-income countries, the costs are around $100 to $200. And in the higher-income countries and countries which are treating more complex cases, like the Russian Federation, it can rise into the thousands of dollars. In America, tens of thousands of dollars. Going back to the question that was mentioned earlier by Peter, is it a good investment still? I mean, all those calculations are made valuing healthy life, not necessarily looking at productivity, but really valuing healthy life. But if we're in the real world and faced with a budget constraint within health budgets in lower and middle income countries, how does investment in TB fare? Well, from the 1993 World Development Report, TB was selected to be in one of the sort of essential package. Here's some recent work from Malawi, one of the poorest countries in the world. They have a budget of $265 million to spend per year on their essential package. When a group of scientists looked and tried to sort of rank those interventions by saying what would give the best sort of cost effectiveness ratio, out of the top 10 interventions, TB had 7 of them, including preventative therapy, first-line treatment for new and retreatment cases, and even multi-drug resistant TB. And again, it's because of that simple calculation of treatment being effective and preventing onward transmission. But the case for TB is not just made in terms of efficiency. There's also the poverty impact that was mentioned in the case of Catherine's presentation. I mean, TB is very similar. The sort of point of danger, if you like, is the point when you start to be symptomatic, you don't seek care, you wait 2 or 3 months before you seek care, you then hit very high cost care. The first couple of months, you're still suffering from the morbidity of TB. So you have this sort of period of 6 months, which is really disabling, and you see sort of large income reductions within families when that happens. And again, a lot of people are starting from a poor base. One of the troubles we have is a lot of people have no income to start with or very informal incomes, and this is catastrophic. So when we see studies again and again, we see people exhibiting coping strategies. So if you like, and I suppose this is typical of endemic diseases, what has happened is the risk has shifted to the individual rather than the government paying to avert this risk. So you see these kind of coping strategies, taking loans, taking children out of school. And the WHO has recently conducted sort of global studies looking at this in many countries with thousands in the sample sizes, and they estimate 30–40% of households in lower middle income countries having a case of TB will face some sort of economic catastrophe measured as sort of 20% of the cost of the value of household income. that doesn't mean that doing something about TB will immediately have sort of an impact on reducing poverty. We did work in South Africa and India, sort of examining how many households could be pulled out of poverty by investing in TB. And because the epidemic is a slow progressing epidemic, we can have an initial effect. We can pull out thousands of households out of poverty, but it will take time. So we also really need to think about the way TB services are delivered and how we support patients and households and communities. So it's not going to be enough just to sort of provide medicines. We're going to need to do more if we're going to have this poverty impact. These arguments, I've said, are sort of very clear. I hope I've convinced you to think, oh, well, this all looks sensible. Then why haven't we done something about this sooner? Well, there has been a shift in global funding, particularly coming from the BRICS, who have a louder voice and have invested money. So if we look at sort of funding for TB over the last 10 years, most of the increase has come from the BRICS, and it has been domestically led. So that's a positive sign. Still, and I'll come back to this, it's not enough. And here we looked at all the high burden countries for TB, and the blue bars, that's the current level of funding per person. And we looked at the fiscal space, or the potential to spend more on TB from macroeconomic growth, from changing health priorities and recognizing that TB is a priority within the health sector. And we saw there was substantial room for further domestic financing in some countries. So there is space, but it's not necessarily been taken. So getting to one of the challenges. So here's an example, very much like the modeling work in polio, where we had 11 different mathematical models examine what would be the best way to spend within the TB budget funds and to estimate the cost of reaching the current global targets. Here's an example from South Africa. This is a cost effectiveness plane. On the y-axis, you see the costs. On the x-axis, you see the health averted, which is in this, or health gain, which is represented by DALY's averted. And this choice we see here is the sort of choice between preventative therapy, expanding access, and improving treatment. And what we find in South Africa is there's no easy choice for a policymaker. They can either invest a little bit of money and have a little bit of impact, or they can invest a lot of money and have a lot of impact. There's no obvious goodbye in terms of, hey, I've got a little bit of money, how do I have a big impact? That's not the same in all countries, but when we presented this, this was done as part of the National Strategic Plan in South Africa, you know, the conclusion was we needed actually a comprehensive package if we're really going to implement controlled TB in South Africa, and that means substantial increases in resources, even though, as I say, the trend is good. So on the left-hand side, we estimated what the budget impact of doing that comprehensive package would be, and we see that even though they've been growing their budget, they would need to sort of begin to start doubling that again, and maybe even tripling it to be able to deliver that high-impact intervention. Having said that, because I mentioned that governments are transferring risk, what we see is by taking back that, there will be substantial reductions in patient costs and the money that they're paying towards TB. And that was the graph on the right-hand side, which is sort of below zero. Two final issues, and I talked about the cost of TB and that it's not just the $20, but it's the health system's cost. One of the issues with TB, and I'm sure it speaks to the people who are developing new technologies, is even when we develop new technologies, we don't necessarily get the uptake. Now, part of it is all that money isn't being released, but part of it is the experience of actually putting those new technologies in countries and seeing whether you get a real effect. And there's a very now notorious example in TB of a new diagnostic which was developed, which was Expert, which all our models predicted would be highly cost effective, top of all those arguments. When we work with the South African government to say, well, let's roll this out in a staged way and evaluate whether it actually has a real mortality impact. Now, that's a difficult thing to do. Most governments won't do that. We never look at mortality. We look at intermediary program outcomes. But we actually found during rollout it had no impact on mortality. And the reason it had no impact on mortality, despite being highly efficient, was because of the complexity of putting new technologies in health systems which are highly, highly constrained. So we've been working with other countries, Georgia, other countries, to say, okay, you have this care pathway, but to make people go along that pathway, to ensure those diagnostics and those tests are used, you need to actually invest in other areas too. You need to invest in things which are proximal, all the things we've talked about, behavioral change, various things that we're talking about, incentivizing. And behind that, to get those incentives to work, there are more distal constraints you need to deal with, which might be to do with the drivers of demand for care. So we really start to need to start looking at investment packages which don't just invest in new technologies. And this is my last slide. And again, just to say this is not just conceptual thinking, but it's real. It's real, and we have models and approaches to examine this. This is work we've done recently, again in South Africa. This shows different packages of trying to find cases of TB, because one of the difficulties with TB is not just having successful treatment, but finding those cases quickly. On the right-hand side, that's the combination package. That's the kind of ideal package I was talking about. The bars there, the different lines, indicate reductions in incidence from implementing that package. If we look at the black bar, that says if we implement that package, we'll get a 10% reduction in incidence. We then looked at constraining that by the human resource availability in South Africa and looking at what could actually be done within that constraint. And we found that within that constraint, those bars reduced to almost no impact on incidence. So again, coming back to this point, the investment in TB control is not just the diagnostic or the technology. The real cost is also supporting that health system long term in the next 5 to 10 years. Thank you.